So I've been asked to speak to you today about management of lower extremity diaphyseal malunions. I don't really have any disclosures. I noticed that I had written that I did, but then I also noticed that they don't count if it's past 12 months. So I've been kind of quiet the last few months. So when I thought about how to present this topic, it's a very complex topic, at least for me. I mean, we all do a lot of malunions and non-unions, and I don't know about you guys, but I feel it's even more common in my practice now than it was maybe 5 or 10 years ago, and I think it has to do something with the economics and stuff like that, but economics of medicine. But when I tackle this project, I was like, man, these cases really stink. I mean, these are the things that you're like, oh man, I got this case coming up at the end of next week, and I'm just dreading it because it's going to be tough. So there's no good answer to many of these problems, and you really have to take each individual case and put your head to the grindstone and come up with some unique solutions to very complex problems. So we'll try to tackle it as best we can here. I thought about how to present it, and I thought, let's start with like the who, what, where, why, how kind of model so that we can get our mind around the whole problem. So let's start with who. Who is the person that's presenting with this challenging injury? You must first and foremost consider host factors. We talk about hosts, A, B, and C. And, you know, A being the perfect host, doesn't smoke, doesn't drink, 18 years old, you know, otherwise completely healthy, completely compliant, has everyone supporting him around him, his family, his social workers, his insurance is great, et cetera, et cetera, et cetera. There's very few type A hosts in the world. Most people are type Bs. The rest of us are Cs. You know, and I'm sure there's a lot of Ds floating around there, even though they've never been actually classified as such. So the age of the patient, the comorbidities that they present with, their bone stock, the degree of osteoporosis that they exhibit, certainly the soft tissue envelope, the patient's socioeconomic factors, and their compliance, investment, and understanding of their expectations of this type of an injury all come into play. And as I said, trauma is not an accident. So unfortunately, a lot of the patients that you're taking care of who are presenting with malunions and non-unions already have a very deep trauma history. Maybe they got into that initial trauma in the first place because of their bad behavior. So a lot of times you can't really count on their good behavior in managing this big, complex complication. That being said, we still have to address it. So what is it? What is the problem? This is the what part. Are these non-unions or are these malunions that you're looking at pure malunions, or are they, for example, associated with an incomplete union altogether? So they're kind of malaligned, partially healed, extremely common. What do you call that? Is it really truly a non-union? No, it's kind of sticky in there when you go back in, but it's certainly not as clean as it was the first time around. So how much of that is an associated non-union problem as well? Is there infection? Am I tackling this operation to try to fix this alignment to address the patient's pain when in fact their pain is related to something completely different, part of the trauma picture, but not really the position that their femur bone is in? So for example, neuromas, hardware that's irritating, heterotopic bone that's painful, you know, chronic regional pain syndrome, all kinds of different factors can come into play that make it difficult to weed out exactly how much of this pain that I'm trying to address by realigning their malrotated limb is really due to the malrotation. And that's sometimes a hard decision to make. Where does the deformity exist? So first of all, where is it? Is it intra-articular? Is it metaphyseal? Is it diaphyseal, like what we're mostly talking about in this talk today? But also, where is it in the planes of the different trajectories of the fracture line? So is it just an angular alignment and malalignment? Is it a rotational malalignment? Is there a length issue? Is it uniplanar in the coronal or the sagittal plane? Is it multiplanar, as often is the case? And what combination of all of these factors come into play? Where that deformity exists is going to affect how you address this injury. And also, where is it with respect to the joints? Is it close by or closer to a neighboring joint and therefore affecting that joint even more. Joint contractures certainly play a role in your outcomes with these malunions and their corrections. If the joint is contracted, then the functional outcome is poor, no matter how accurate you get the alignment ultimately. Also, a tight joint or a stiff joint can contribute to ultimate non-union of the osteotomies that you create. And sometimes the joint is deformed because it's a compensatory deformity from all of those months or years from walking in a bad position. And so you have to take that into account, because if you correct that deformity and they have significant compensatory changes in their joint, they're still not going to have a comfortable limb. And this is not my patient, but I have several of this guy floating around, so I used the picture. Why would you undertake such a kind of ridiculous, almost Herculean undertaking or endeavor? At times it's overwhelming when you're dealing with these complex malunions. The indications would be the presence of disabling pain, which we've already said it can be misleading, severe functional disability, which you may or may not be able to improve in the end, even if you get the leg straight, potential, that kind of nebulous, what will this do to the joint in the future? Okay, the mechanical significance in the years to come. And in some patients' case, cosmesis. People hate it when their right foot is pointing out towards Cooper and they're living in Philadelphia. They don't like that posture. So there is, their perception of this is killing me is also influenced by the fact that they look at it every day and it just drives them crazy. Now we're up to, that's who, what, where, now how. How will we carry this out? Well, it takes a tremendous amount of preoperative planning. This is not the kind of case where you just walk in on a Monday morning and say, okay, what do we got on the schedule today? And try to tackle it intraoperatively. You should never do that, first of all, and you should never teach your residents that, certainly. But a lot of us do a lot of preoperative planning in our head as we get further and further along. This is a case that you need to sit down and draw it out, good old-fashioned way with tracing paper, and see where the fragments are going to move when you make your various osteotomies and so forth. Especially osteotomies that are multiplanar or more oblique in nature. They can be very complex. You want to get, in order to accomplish this preoperative planning, you need to get x-rays, not just regular x-rays, because you would think, okay, I'm working on the tibia, I'm going to make sure I see the full length of the tibia and I have knee and ankle included completely. Okay, that makes sense. But don't forget to get x-rays of the other side so you can compare. Don't forget to get, if you can, your hands on the original injury films, even if you weren't the treating physician, because seeing how that fracture behaves itself initially can sometimes give you little clues about how to pull it together now. Get weight-bearing films if there's concern about the joint and how it's responding to this deformity, like I mentioned earlier. And also get oblique radiographs, intentionally oblique radiographs. We hate obliquograms, right? We're like, this doesn't really show me what I'm trying to see. It doesn't make my x-ray look good, my final x-ray. But in the case of malunions, many times, and non-unions too for that matter, the biggest deformity or the biggest evidence of that unhealed fracture gap in the non-union is best seen on an oblique film. So use your oblique films to help you in these cases. CT scan is also important. So certainly 3D recons can help, in addition to the standard CT images. And scanograms, if you're looking to better establish an understanding of leg length discrepancies down to the, minute detail of exactly how many millimeters are we talking or how many centimeters. And also rotationally, because you can see on this CAT scan, for example, that if you get the scanogram and you know that their hips are symmetrically aligned, and by the time you get down to the knees, they're not, you can calculate then the degree of malrotation that you need to correct for intraoperatively. Sometimes MRIs can help as well for articular injury or associated soft tissue injury if it's near the joint. So continuing on with how will we carry this out, you do have multiple options available for creating osteotomies. You don't just have to take a osteotome to it and start whacking away indiscriminately. There are simple opening wedge and closing wedge osteotomies, and you need to take into account not just what you're going to do to the leg length discrepancy when you make either an opening or a closing wedge osteotomy, but also whether the patient can fill a gap that's created by an opening wedge osteotomy or not. You need to consider the possibility of a dome-shaped osteotomy to have better bone contact. Oblique osteotomies, again, to address these multiplanar deformities. And all of these things should be done with tracings and cutouts and little sketches like you see here, taking into account both the anatomic and the mechanical axes of the limb. I don't know anything about this. This is just to show you how incredibly complex it can become. These guys are doing all kinds of work with, like, I don't know, what's that, you know, like when the computer creates the bone, and then they have these multiple different measurement devices, and they recreate the deformity and then straighten it, and they know exactly what to. This is computer generated, and it just shows you how tremendously complex it is. So if you do have something along those lines, perhaps a computer generated program would be ideal for you, and that's often used in things like you know, thin wire circular frames and so on. Implant choices are kind of, you know, across the board available to you, and you should pick and choose based on the particular nature of the injury and what part of the limb you're working in. So plates and screws obviously provide very good interfragmentary compression and can achieve essentially a perfect reduction between two fragments. But they do require better soft tissue coverage, and they usually are used more frequently, at least, in periarticular or metaphyseal, diaphyseal junction type injuries. Intramedullary devices are an option for diaphyseal deformities, but you have to be very careful. A nail will not reduce, you know, you can get a plate reduction. We talk about that all the time. A nail will not reduce a fracture for you. You need to make sure not only that this malunion that you're addressing is reduced, but that it maintains that reduction as you're advancing your nail. So things like blocking screws, for example, polar screws, or other techniques to ensure that the nail does not create a deforming force that either recreates your deformity or even worsens the original deformity as it passes by. So you be careful in that decision making there. And finally, the external fixation devices, of which they can be very simple and even temporizing. As you see here, they can be used as reduction techniques in the operating room, or they can be maintained post-operatively to supplement your internal fixation, or again, mostly in terms of a thin wire frame, since the length of time that it needs to be kept in place is long, and the pin sites become an issue with standard frames. The thin wire frames allow for more longevity, and obviously, especially in conjunction with the computer programs, tremendous control over time. So you can achieve corrections, dramatic corrections that you couldn't do in the operating room acutely by dialing in these changes through the thin wire frames over the course of time, allowing the soft tissues to accommodate the stretch slowly, and therefore have less issues with wound healing, nerve neuropraxias, and stuff like that. You can't do a talk on this topic without mentioning one of the gurus, Rob Rosbrook. He's very interesting guy, very, very, very smart, and he's helped me out with a lot of cases. I send guys out to him still if it's a super complex, you know, I dabble in this Elizaroff/Taylor spatial frame stuff, and I certainly can, I think I'm comfortable with it for acute injuries, but when you get to these really multiplanar deformities, and you know, he does this concurrent with a expanding nail in the femur to give them back some of their leg length and the other, you know, from the other side, and all different stuff. He's really a wizard. So certainly you need to mention his technical prowess and the types of frames that he uses. Those things are extremely difficult for patients to live with, and very difficult for physicians to manage. And he has a huge army of people that are taking care of these patients and facilitates all of that, you know, stuff that goes along with sticking somebody in one of these frames. There's a lot of different things being written about different techniques as we get a little bit more comfortable with the idea of takedowns and so on. The technology is improving in terms of different contoured and specialty plates, prosthetic plates that you can place now around, a lot of these periprosthetic plates that were originally designed to go around a total joint can be used around existing hardware if you just need to make some nuanced changes, and I'll show you a couple of pictures of that in a minute. But some of the stuff like this article, George Russell and a couple of the other guys from Harborview were involved too in a multi-center study, and they're doing a clamshell osteotomy now to achieve reduction of things like this femur and this tibia that you would be hard-pressed to do it with more traditional osteotomies. So for femoral shaft malunions, some numbers that get thrown around. This could be considered surgical in nature if you have shortening greater than 2.5 centimeters, angulation greater than 10 degrees in any direction, internally or externally rotated limb to the point that the knee cannot be aligned with the forward motion during gait. That's very disturbing to people. There's a question as to whether these abnormalities and malalignments actually cause long-term arthritic changes or not, and some studies show that they don't. Okay, here's a study that showed that there was no significant arthritic changes in this population of 64 femoral malunions over the course of 42 years. So it's a huge time frame. But patients do have pain from these deformities, and they do have significant gait disturbances. And for that reason, you need to consider intervention on many of them. So here's just a couple quick examples. This is a case with a 62-year-old male, hypertension and non-insulin-dependent diabetes that was diet controlled. He was a year out from a femoral nail at an outside hospital that was placed following a fall on the ice. This guy had persistent thigh pain and ambulatory dysfunction, and he went doctor shopping. He went to a lot of different places to figure out what he could have done with it. This is his x-rays. So again, he's one of those guys who has a malunion as well as a non-union. And what's hurting him more? Who knows? It's a little bit of both maybe. But we know that varus deformity and apex anterior flexion deformity are the hallmarks of a subtroch fracture, and that deformity in and of itself contributes to the creation of the non-union because the mechanical axes are off. And so if you're going to go in and try to correct this non-union, let's just say you're saying this is mostly a non-union, not a malunion, you still have to correct the malunion component of it, because if you just fix it in that same position and try to bone graft it or something like that without correcting the deformities, I think you'll have less success in achieving your final goal of a straight healed femur. So how are you going to do it? He's already been dynamized. It didn't work. There's a million ways to skin these cats, so it's not like we have any one right answer, but in the interest of time, I have become a huge fan for non-unions and some malunions of plating over top of nails. The nail has to be dynamic at that point in time, and you can't be like rammed right up against the end of the subchondral bone where you won't get any more compression. So you have to have that in your favor. But the technique is, after dynamizing the nail, applying this plate in compression. And you use a variety of techniques to achieve that, including including some companies' compression device and stuff like that, to get maximum compression in the operating room, and then apply this periprosthetic plate around the implant that's already in place. Why? What's the advantage to that? Well, number one, the guy can walk on it full weight bearing day one. There are no weight bearing restrictions. If you took this nail out and did, like, say, a traditional blade plate or something like that, which is one of the things that someone had recommended to him. That person is non-weight bearing for a long period of time. That's a big operation for an old guy to go through, and he just wasn't having any of that. I mean, it's a good technique, and it's very tried and true, and I bet you they would have healed it too. But this compression plating around a nail has become like my favorite new thing to do because it is so effective. I really have had terrific experience with it. And this guy, in a little over 9 months, is solidly healed and straight. I was able to, we were able to achieve the reduction around the nail. There was enough wiggle. And so he was able to get on his way. He's satisfied with that. For tibial shafts, the varus deformities are obviously more poorly tolerated than the valgus deformities, and surgery is indicated for anything over 12 degrees in the valgus plane, but only 6 degrees for varus. External rotation deformities of 15 degrees and internal rotation deformities of 10 degrees or more are poorly tolerated, and that's usually one of the biggest problems I find in tibias that come in with complaints. It's like my leg is pointing the wrong way. Obviously, anything greater than 2.5 centimeters of shortening is also poorly tolerated, even with a lift. So here's another patient, 68 years old, heavy smoker, COPD. She had a motor vehicle collision and had an open distal tibia fracture. This is like the kiss of death. She presented a year out with exposed hardware, thank you very much, and tibial malunion, non-union. This is after we took the hardware out, we put a vac on for her wound, we nursed her along with antibiotics. At one point in time, I think she had some beads. I can't remember exactly. But she has this, again, this incomplete union. It's not a total non-union. There's some bridging callus. But by the time we got in there and cleaned it all out aggressively, she had frank motion through. So that, I guess you could call that my takedown of the malunion and osteotomy. It was really a debridement more than anything. We put in her frame. We were able to get most of the reduction on the table, and then the nuances of it, we messed with the computer a little bit. And she was, despite all of her comorbidities and everything, once she had alignment and better wound care and stuff, she was able to go on and heal this successfully, so she was thrilled. So basically, just in summary, you want to restore the normal axial alignment and with attention to both the anatomic axis and the mechanical axis. Make sure the knee and the ankle joints are parallel to the floor, that the hip is covered, obviously, and the tip of the trochanter, if you're dealing with proximal fractures, is approximately at the center of the head, so that you have the right lever arm, and that your leg lengths are equal to avoid gait difficulties. You have to have good motion above and below the malunion, through the joints above and below the malunion in order to achieve a good functional result. Most malunions are not strictly in orthogonal planes, so make sure you look at all these oblique views and 3D CTs to help you in that regard. And remember that the most common complication, up to 15% or more, is associated with surgical correction of malunions is continued malunion, all right? They're still not right, and that's a big problem because now you've also given them a new wound, a new non-union to deal with as well. I just wanted to show you this really fast to show you, this is to prove a point that you don't have to fix everything. This is a 70-year-old female with cognitive disabilities who fell at her group home. She had had DDH as a child, and at 18 months she was fused in her hip. So rather than trying to correct her, everybody's like, let's give her a total joint. She'll walk again. She's 70. She's had this this fused hip for 68 and a half years. And the joint guys were like, we can put a total hip in her. I'm like, are you guys crazy? We don't have to fix everything. Let's just let it be like it is. So we just did that. And she did good. So that just shows you that you don't have to fix everything, and we have freaking awesome jobs. All right, thank you very much.